I think it's difficult to talk about how to have conversations with people as a lecture. And, it's just not something that lends itself. It's important for us to, in some ways, try to put ourselves in the minds of patients that we're talking to, really to think about the best way to do it. So let's go ahead and begin. So rather than talking about how to deliver bad news, we like to reframe that a little bit as how to discuss serious news. And I don't think it's a subtle distinction, because what defines bad news is really kind of up to the eye of the beholder. The bad news to a patient may be something as obvious as recurrence, but bad news may also be my white cells are too low today and I can't get chemotherapy, or the doctor has an idea for a new kind of treatment. That must mean he thinks something's awful. And so I'm going to reframe this a little bit, and let's talk about how to discuss serious news. So the objectives for this really will be to think about strategies that we can use to improve the understanding of the risk and benefits of transplantation. And I imagine most people here have heard feedback about patients that have gone through transplant, but not until afterwards do they really get a feeling for what this is about. And often we'll hear comments about, I had no idea it'd be like this. This is just a very difficult conversation to have. And then also, I look around the room and I think there are likely a lot of very experienced providers here, but I think the challenge of how to talk about serious news is not something that we ever master, because everybody's different. None of us can ever come into these conversations without really having part of ourselves involved. And just the emotional impact and the effect that we have on other people is something that I would hope all of us are always engaged with. The opposite of that, I think, is burnout. So let's talk about some routine for discussing serious news. Okay, so a couple pre-tests. So first of all, imagine this situation. So you have cancer. Your doctor tells you that after your surgery, that without chemotherapy, 50-50 chance that you're cured. With chemotherapy, that number goes up to 60% chance of cure. And you know that without a cure, you're likely to die in a relatively short period of time. And the risks are 100% chance that you're just going to be miserable for 6 months. And it's going to cost you a lot of money. It's going to cost you your car. So I just want to show of hands, how many want that treatment? Okay, so there are a few people. Okay. Another scenario. Again, you have chemotherapy, but without chemotherapy, there's no cure. With chemotherapy, there's a 10% chance of cure, but the same issues. Without a cure, you're likely to die within 6 months, and the risk, again, 100% chance of misery for 6 months, and it's going to cost you your car. Now, how many people want the treatment? Okay. So the response here tells me that there definitely is more experience in the room. Now, there's only a handful of people in the room that rose hands. So let me again, raise your hands high. Let's go back to the first option. How many people, raise them high, how many people want chemotherapy with the first option? Okay, good. And now with the second. Okay. So this is interesting to me, because this thing I have done in several venues, and typically the response is that most people are not interested in chemotherapy in this situation, but they are interested in chemotherapy in this situation. And generally, when surveys are done, what people who are in the situation will think about is it's not so much the 10% that they're concerned about, it's the relative value. And so and I put this definition for conjecture up here because I'm going to use some conjecture. A lot of these things are not unstudied, but it's definitely true, and there are a number of books that look at this, that our minds are not very good at evaluating percentages. But this is what we love to communicate in. We love to give people percentages. What our minds are good at are attaching emotional value to risk of losing things and gaining things. And in general, people are risk averse, and that's particularly true when it pertains to somebody's life. So, this giving chemotherapy for that 10% chance of survival, generally that's less attractive to providers and somewhat more attractive to patients. And so it's this kind of dynamic that we need to think about. So if our minds don't think about percentages, how do we communicate percentages? And there are definitely studies that have looked at what people hear when you use a number. That, for example, we had a study done a few years back, a sociologist who would evaluate and question people after a discussion with a physician. And when they heard percentages, it was very interesting to hear what patients thought they heard. So 20% might translate into an 80% chance of cure. A 50-50 chance is that people walk out thinking that they're one of the 50%. That's what the doctor said. So for them, it's going to work. And so one of the questions is it better to talk in numbers or simply to make statements? For example, 100%, I'm certain that this will work. 10%, I'm pretty sure this won't work. How many people hear that? How many people use that kind of language when they talk about the odds of something working? Instead of using the number, you simply say, I don't think this is going to work. That's something that's very seldom done. Okay. Here's the other pretest. So I'm going to give you 2 treatment options, and here's where your card's important. So everybody make sure you've got a card. And the way I want you to do this is I want everybody to stand up with their card. And we're going to begin 2 treatments. Okay? Okay. And so everybody look at your card, and you have a disease. So there's a disease that you have, and your doctor's offering you 2 options. And I'm not going to describe the options. I'm just simply going to show you what happens. So I know that these options, one option is potentially, well, I'm not going to say any more. So here's the treatment. So we're going to start treatment A. And so here we are in February, and I'm sorry to say, but that if you have a Jack or a 3, the treatment has not helped you. You've died. And so if you have a Jack or a 3, sit down. Okay. All right. Spring's come. It's April. If you have a 4 or 5, I'm sorry. You've died. June. It's summertime. It's pretty. I'm sorry, but if you have a 6 or a 7, you've died. Have a seat. August. If you have an 8 or a 10, I'm sorry, you've died. October. If you have an ace or a 2, you've died. I'm sorry. It's December. If you have a king or a queen, you've died. I'm sorry. Okay. Raise your hand if you're alive. Congratulations, that's wonderful. How many people want another option? Yeah, okay. All right, everybody stand up again. All right. Treatment B starts. It's February. I'm sorry. If you have a spade, you've died. Okay. April. If you have an ace, king, or queen, you've died. June. If you have a 2 or a 3, you've died. August. If you have a Jack or a red 4, you've died. October. If you have a red 5 or a 10, you've died. December. If you have a black 6 or 9, you've died. All right. Wonderful. Okay, thank you. Now, here's what I want to ask you a question. How many people want treatment A? Okay, raise it high. Okay. Everybody look around a little bit and see who wants treatment A. And I'm not doing this to embarrass, let's give people an idea. How many want treatment B? Okay. How many people who are spades want treatment B? Okay. So here's the question I want to ask you, and let me just ask you and have people who wanted treatment A, why? Why do you want treatment A? Does anybody care to say anything? Okay. People who wanted treatment B, why can somebody say why you wanted treatment B? More people alive at the end. More people died early, though, right? So, so wasn't without early risk. Now, what if I were to tell you that treatment B, the first year is absolutely miserable, and treatment A, quality of life, is pretty good? Does that change anybody's opinion? Okay. So this is roughly modeled after what Kaplan-Meier curves might look like for people, particularly an older person who has MDS, high-risk MDS. And so the question is, within this room, and look, we're a transplant crowd, but in this room, there's a lot of heterogeneity over what's seen as the better treatment. And the question is, how do you communicate that to a patient so that they can make an informed decision about what to do? And so, the picture's on. Do you really just focus on the probability? Let's just look at numbers. And then the question is, what numbers do you look at? Do you look at the numbers within 6 months or a year or 2 years? Do you focus on the likelihood of being around to watch, way in the future? Let's look at 5 years, 10 years. Or do you just look at quality of life issues? What's going to be good for you in the immediate future, your quality of life? And I won't ask anybody to respond, but the other question is, how much would you be willing to spend on treatment A or treatment B? So would you sell your house? Would you spend all your retirement for treatment A or treatment B? Would you spend all of your retirement and all income, even though you're married and have a spouse who you expect to live beyond you? So I'm raising these issues because I feel like this conversation is extraordinarily difficult. So for most of us as transplant providers, the decision can look two different ways. So these are two Kaplan-Meier curves, and I think most of us recognize which curve is which. So this would be a more typical transplant curve. We know that transplant carries a lot of early risk for the hope of a later cure. And the other curve might be, for example, the curve of somebody who has MDS, where we know there's going to be a steady loss of life, and nobody ultimately will survive after a certain period of time. As a physician, I feel like this is a relatively easy scenario to recommend one treatment over the other, particularly if it's somebody who's younger, where the future has a lot of meaning. The life lost up above is clearly outpaced by the life gained down below in the future. But what about this situation? So this is a situation that's much more resembles an older patient with MDS. This is quite a bit more difficult. What is the best treatment here? So these people out here might give you a pretty strong argument that treatment B is better, but there's a lot of life lost early on that might have not been lost have people taken the non-curative treatment. And it's not a matter of what's the better option, but more importantly, we live in an era of patient family-centered care. How do you communicate this? How do you help people make this decision? In this room, we could not get agreement because we all see this very differently. So think about a patient. So the elements of informed consent really are three. The consent needs to be intentional. They need to consider the pros and cons and make a concerted decision. They have to understand what they're getting into. And of course, there can't be coercion. Well, this I think is very difficult, and it's arguable that many patients really, really make it with all three of these issues. And I'm just going to show you one piece of evidence. This was a study done in France, I think, in Europe anyway. And what they did, investigators had people record the conversation between the physician and the patient. Now, the physicians were coached, had some training on how to do informed consent, so they went through and mentioned all these various elements. And then after the conversation, the investigators met with the patients just to have a conversation about what they understood and what they heard and what they remembered. And so, for example, almost everybody remembers talking about death. The physicians were not perfect at bringing it up, but pretty good at bringing it up. They repeated the issues with death at least 3 times, and patients recalled it well. But then look at this, toxicity. So mentioned about half the time, like this would be a really, really hard thing to do. And look at how many patients recalled talking about toxicities of treatment. GVH. So GVH was discussed by the physician the most of all these elements, but look how many people actually recall talking about GVH. So I don't know whether the experience is true in here, but we hear pretty frequently of patients saying, I had no idea, we never talked about this. Or, I feel like I've traded one disease for another. Why didn't you tell me that this could happen? So those comments are not infrequent at our institution. What patients really key on, not surprisingly, is a chance of cure. So what they remember is talking about dying, and they remember talking about being cured. And that's what's most important. So again, reflect back, intentional understanding. Now, no one's being coerced, but you could argue, do they understand? And this is occurring in the setting where the physicians were trained before the study to give consent a certain way. This is another study that raises this issue about understanding. So this is a group of patients with metastatic lung cancer and colorectal cancer who then were queried as to really the purpose of the chemotherapy. And when asked whether this chemotherapy is likely to cure their disease, if they had metastatic lung cancer, 50% of the patients thought that the goal was cure. 50%. If they had metastatic colorectal cancer, that number was around 60%. Now, it's easy, you could ask the question, is this really just a matter of the provider not giving them good information? And that certainly could be part of it. But I'd like to propose that we have many defense mechanisms as we hear serious news, and some of these defense mechanisms are simply, I'm not hearing that kind of information. I know that I'm unique, and that do we respect that defense, or do we try to break it down? I'm going to argue that you have to respect it. But it is important that we acknowledge it. Okay, so how do we make connections with reality? Again, if people are to have an understanding for what we're doing, somehow we have to connect their perception with reality. And I don't have an answer here. I'm going to propose 2 ideas, one of which is being studied at our institution and has been written about in the literature, and the other one is the one that we do on a more systematic basis. Toby Campbell at our center is really a palliative care doctor who focuses on communication. He has a large grant within our institution to look at this basic tool where they sit down and they compare 2 options, and on a piece of paper with these images written on the piece of paper, he then handwrites best case, worst case outcome for each of the options, and then he just simply puts a dot on where he thinks the patient fits in his likelihood, his prediction about where he thinks the patient may fit in terms of risk. And the idea is to give the patient a visual representation, something that they can see, something they can take home with them, really to compare one option versus another. We know that and we can reflect back. So we've been hearing lectures now for a week. When you go home tomorrow, if you were tested on what you remembered, think about what percentage would I actually remember? How many people remember 90% of what they heard? Yeah, 10% maybe? I hope 10%, yeah. So maybe 10%. I think studies generally say we remember about 10 to 15% of what we hear. Something along that line. So imagine the consent that lasts an hour sitting with the patient talking about what we're going to do, and that patient is sitting there nodding, yes, yeah, oh, sure. They walk out of the room, what do they remember? Well, at least this is a way of giving them some visual representation of what's there. The other approach that we take, particularly with respect to MDS, is to look at time-related goal setting. And what I mean by that is instead of focusing on what it's going to look like way out here or at 5 years, let's look at what it looks like in 3 months, a year, and 5 years. And if we do this, or if we go to transplant versus if we use, for example, azacitidine. And so let's talk about quality of life at day 100. Quality of life with azacitidine, pretty good. With transplant, it's miserable at this point. At a year, quality of life is better with transplant. If you're doing well at a year, the odds are pretty good it's going to stay that way. At 5 years, transplant, if you have a transplant, this is really the only option that gets you to 5 years. And this is important because there are patients who the immediate 1 to 2 years in front of them is simply more important than the time beyond that. And I know for an example, specifically have had mothers of children in high school. All they want is to be kept alive until their youngest child is out of high school. That's the most important item on their plate. And so if transplant is going to really reduce the risk of that, even though that may make it more likely that they can see their children graduate from college, it's the high school years that are more important. So we've had people make decisions on that basis. Okay. So after a very difficult conversation, one of the things that is being written about quite a bit now is this idea of sharing decision making. And I'm going to make the statement that I feel we definitely need to share decision making, but what we owe every single patient is a very clear and firm recommendation based on our expertise. It needs to be black and white, and I feel like every patient knows that. They need to have the space and the freedom to choose what you don't recommend, but every patient deserves a recommendation, in my opinion, and I think there's quite a bit written about that we've gone too far in the shared decision-making, essentially giving people that simply are not qualified nor have the experience to really know what's best. And although we need to communicate that, we owe it to every patient to have a recommendation. Okay. I'm going to leave behind the consent, and then let's focus a little bit on communicating with really ill people. So first of all, I'm going to make a plug for Tony Bach, who I'll acknowledge at the end. He put together a group of people who have been offering ways for people to meet and learn how to communicate better. And so I'm drawing very heavily from his book and some of what I'm mentioning in this. And Tony talks about the following basic principles. When people are really ill, it's first of all extremely important that we start conversations with the patient's agenda. We all have our own agenda, but when people are ill, it's important that they feel like they're heard, and that starts by acknowledging their agenda and what they need to hear about. One thing that is really an important skill, and I'm going to generalize by saying nurses are much better at this than physicians are, and this is something we really struggle with our residents and fellows. It's important that we track and understand when patients need emotional information and when patients need cognitive information. It's very important that we stay with the patient's agenda, particularly when items are really heated or pressured, and that we allow them to move one step at a time. It's important that we always articulate empathy explicitly. Empathy is a way of patients feeling that they're heard, that they're respected, and that we are not automatons that are making calculations, but we're actually real people who are trying to treat real people. It's important that we always focus on the things that we can do before we talk about what we can't do. And it always breaks my heart when somehow patients get the message that the doctor said there's nothing more they can do for me. That's a horrible message, and it's never true. So that should never be a message that any patient ever hears. It's important that we focus on what we can do. And then it's also important that we think about big picture goals. It's so easy, particularly in the intensive care unit, and this has been written down a great deal. It's much easier in the intensive care unit to get focused on the fact that the urine output's a little bit better, the creatinine, came down a little bit, and not stand back and look at the bigger picture and keep the focus on the big picture. And then it's always important in busy days with cell phones and smartphones and everything else that we devote even a few minutes of straight eye contact, undivided attention. Now, let me address this emotional versus cognitive data. Does anybody watch Modern Family? Okay. So how many people remember the episode, and I'm drawing a blank now, the episode. It's this episode where Phil doesn't want to waste the trip to the beauty parlor because otherwise the money just goes to charity. And so Claire doesn't want to take it, so he goes and he gets the facial and the fingernails. Anybody remember this? Okay, so here's what happens. Phil has a conversation with his wife while all these ladies are kind of taking care of him. And Claire's going off about the fact that kids are misbehaving and all these things are going on. And as she's relating all these events that she's trying to keep up with, he's simply saying, well, you should do this and you should do that and you need to fix that problem, and if you just did this, that would work. And they're not getting anywhere. And so when he hangs up, all the women stare at him, and you can see that happening right here. Like, what in the world was that? So is that what she needed? Was Claire calling for advice? No. What did she want? She wanted some support. And so the same situation's here. So this poor guy, his team just lost. He jumps up. How could this happen? So does he really want somebody to stand up and kind of give the breakdown, play by play, how the Jets lost? No, that'd be a life-threatening intervention right there, right? That's not what he wants. He wants you to jump up. Yeah, how could this happen? I can't believe this could happen. How could that happen? So what's happening is people are asking for an emotional connection, and you need to acknowledge that, because if you don't acknowledge that, you can't move on. Because at that point, we're not recognizing that human situation that people are in. And so what this guy wants is somebody to jump up and scream and yell, and what Claire wanted to say, you are having an awful day. That is a really bad day. And if you just think back a little bit about interactions you have with patients, think about the time that you walked in and somebody said, God, Doc, how am I going to do this? Think about what they're really looking for. And so you can imagine this situation. How am I going to get through this? So the cognitive response to that is, let me get a piece of paper out, and I'm going to put a list of 10 items that you're going to have to start doing to get through this. Step 1, step 2, step 3. That's not really what she's looking for. What she's saying is that I'm scared. And it's important to simply state that. You must be scared. I'm going to be with you. When somebody says, didn't you tell me that this would cure my leukemia? So how many times have you heard that? Are they really challenging you? Is it really time to call the lawyer? Is it really time to, get the consent form that they signed? See, I told you. No, that's not what they're looking for. Is an acknowledgement. You must be angry. You've done everything. You've done everything we could ask. So you've got to acknowledge that emotion. He says, when will I be able to work again? Is he looking for a date? Well, he might be looking for a date, right? But he also might be saying, this has got to be frustrating. Who you are is your work, and you can't get back to work. So I hope you feel better soon. So what I'm going to encourage you to do, and again, many people in the room are probably very good at this, is every statement that comes out of a patient's mouth, particularly when they're in a crisis, you have to think about when they're actually looking for data and when they're looking for acknowledgement of the humanity of the situation that they're in, and acknowledge each of those. So how many people have heard of spikes? This is a kind of an algorithm that we like to teach. So in thinking about kind of strategically, how do you structure, and particularly when you're talking about very bad news, very serious news, let me go through this. So if there is a time that, for example, you need to sit down and talk to somebody about the fact that their leukemia is back, this is a wonderful algorithm to think about the best way to do this. And so the S in spikes is setting the scene. And the basics here are to make sure it's very clear. A lot of times we end up breaking news to somebody that we're not primarily caring for. And so it's amazing in the hospital how many times physicians go to talk to patients who they don't know, and the physicians don't introduce themselves. My name is Dr. So-and-so. I'm the partner of so-and-so, and I'm here to talk about some serious things. It's important to acknowledge everybody in the room because families and friends, these are obviously important people, and it needs to be made clear that what the situation is, and also to allow the patient to kind of allow friends and family to come and go. It's important to make the connection first, and of course, anytime that somebody is going to talk about real issues, you got to put the computer away. Sitting is remarkably important, and there's some studies that show that in primary care docs, when they talk about serious things, that sitting versus standing actually has some influence over whether physicians get sued. And so sitting is a commitment. I'm here for you. Standing is I'm here to escape. I'm here to deliver a bomb and escape. So recognize the difference between a commitment to the patient and a commitment to the door. And then, of course, anytime, as I mentioned, undivided attention is important. Whenever bad news is delivered, one of the most important things is to make sure that the patient understands the situation. So testing perception. So question, for example, is, where are we and where are we going? It's really important, particularly if patients have been feeling well, things have been going great, that you acknowledge the fact that you're going to shake their world and ask permission. Is it okay with you if I talk about some serious things that I've just found out? Because there are many people who will simply say, hold on, I've got to call my wife. Or, hold on, you got to give me a few minutes. And giving them permission to accept that information, I think, is always key. It's important to put the bad news in the context of what people are going on. So I like to simply ask, can you tell me a little bit about what brought you in the hospital? I know what brought them in the hospital, but this is a way of having them kind of recount the story so that they bring everything together. It's very important that we get people to, there's an acronym or process, ask, tell, ask. And this is a way of, again, engaging in the patient in the delivery of the news. So one way you can do that is by simply asking, I want to make sure we're on the same page. Do you remember when we talked about problems that could occur? Okay. When we're testing perception, the two basic themes are illness understanding, making sure people really understand what the situation is that they're in. The other way is really to thinking about setting agendas, setting hopes and goals. And so, again, there's always hope for something. It doesn't matter how bad the situation is. And it's always important that we kind of test the perception of the patients and really what they're hoping for. Okay, getting an invitation. This is really important when we're on the phone, especially because, again, we don't want to deliver the really bad news as people are driving down the highway. So invitation, it's always important to ask permission. Is it now okay time to talk? I like to ask people, how much information would you like to hear about today? I like to ask if people want to pause and wait until somebody else comes in. We know that once we deliver that specific fact, that the ability to hear other things drops just about to zero. This idea of a warning shot is very important, and that's simply because it prepares people to listen. And there are a lot of ways that this can be done, including things like, this is not the news we are hoping for, I have bad news is an obvious one, I'm really worried about the findings. I like to use I'm really worried, because the fact is I am really worried. I don't want to be in there giving bad news as much as the next guy, and they certainly don't want to hear it. And again, this is a way of not only letting people know that you have bad news, but also that you care. This is not just part of the job. This is something you don't like to do, and you're worried about it. Now, when you get to the actual knowledge piece, it's very important to be clear about the facts. Clear language, short statements. I talked about this intensive care unit. So again, in intensive care unit, it's very easy to obscure big picture by focusing on little details. And it's not surprising, in an ICU you can imagine the wife of a patient who's sitting in the room, and every doctor, every specialist that comes in that talks about the urine output's a little better and this is a little bit worse, and we're going to do what we can to make the blood pressure come up, and the lungs are stable today. Well, none of that gives her an information about what the larger trajectory is. And so it's important to be clear. The bone marrow shows the leukemia is back. All the details really don't matter. The tests show that you have bad GVH, the type that people die from. The treatment we're giving isn't working. So very clear language. And the one thing that also has been studied well is physicians, nurses, none of us, we're all people, we don't like to use the word dying. We don't like to use the word die. But we all understand what that means. And so if people are declining, there's quite a bit of evidence that clear language about your impression, I think you're dying, is much, it relieves stress. It's clear thinking. It clears a lot of ambiguity about the impression. It gives people a real feeling that that you care, that you're keeping track of things, and that you're not hiding things from them. Now, not everybody wants to hear that kind of language, but it can be a very clear way of communicating bad news. The other thing that's very difficult to do is allow silence. But it's critically important that when you deliver that bad news, I think you're dying, that then there's a pause and silence. And there are lots of tools. I know there are people that study mindfulness. We'll talk about then counting or following their own breaths or other things, just to let the energy in the room sit while this information sits with people. But the important point here is people need to have space to process bad news while you're there. Okay, empathetic statements. So part of showing that we care is actual showing that we care. And the way people do this best is really acknowledging the emotion, and this we touched on earlier. Naming the emotion is the most straightforward way to do it. If somebody's angry, you can say, I see you're angry about this. I think I would be too. If somebody's sad, boy, this is really making you sad. Naming it is simply a way of acknowledging you can see what's happening. Understanding is always a tricky thing because none of us can say, I know what you're going through. We have no idea what they're going through. But we can say things like, I imagine this is really hard. That's again a way of conveying that you are empathetic. You can somehow at least acknowledge the pain that they're going through. Respect is always important. Support, making sure that there's always follow-through. Sometimes exploring questions when people say things that kind of catch you off guard. Tell me more about that is a nice way of eliciting more input. And then what is just a beautiful way to start many kinds of, connecting statements is to start with I wish. I wish there was something else I could do. I wish I wasn't here giving this kind of news. I wish you could be at home with your family. It's a very nice way of really expressing your empathy and the fact that you care. All right, it's always important after this to summarize and make some plans, to think about where we're going. And the one thing I'll point out about the challenge with transplant is, we treat horrible diseases that people die from very quickly. This is not diabetes. We don't have diseases like that. And so the difference, we're looking at curative therapies for terrible diseases. And so when things come back, it is really an about face. I mean, it is huge. This is terrible news. On Monday, we're all happy about the counts look great and everything's going good. On Friday, you see 20% circulating blasts. We've all seen that situation. So imagine that about face. So this is really a difficult thing. And we can't predict the future. So I tell this, and I think all of us use this over and over again. The fact is we can't predict. I could make some guesses, and I make it very clear that when I try to predict, it's guessing. But how do we do this if we're really kind of turning things around? It's very important that we then start to reframe goals and reframe hope. So in the beginning, when we're hoping to cure, we can talk about cure, but if we're not talking about cure, we have to reframe hope. What are you hoping for? The disease is back. What are you hoping for? And keep that idea front and center. So what's most important to you now? What do you most hope for? What are you worried about in terms of your future, the way this is going to go? And I think when you use that word hope, it avoids the situation where people leave the office and say, the doctor says there's no hope for me. That's never a message we should send somebody home for, or home with, I should say. All right. So I like to use a statement. I want to hope for the best, but we also have to plan in case things don't go the way they're going. Often you hear about people talk about miracles. How do you address that? I'm waiting for the miracle. Should you say, I never see miracles here? Well, right? Nobody sees miracles often. That's why we call them miracles. So that kind of language never helps anybody. If somebody's waiting for a miracle, I would love to see a miracle. God, that would be so good. But we do have to think about what happens if a miracle doesn't happen. Okay. One of the issues that I think transplant providers deal with a great deal is this sort of 11th hour hero. We generally take care of people who have adult children, often who live out of town, who want to come in and do everything that we can. And it's very important to acknowledge that the son or daughter that travels from LA overnight to come in and see Dad when the leukemia came back, they're there because they care. And so that 11th hour hero needs to be recognized as an 11th hour hero. And so I like to make statements when people come in and they have these aggressive ideas about what we're going to do, to acknowledge, I can see you really care for your dad. My gosh, you flew here overnight. And let me now tell you the conversation that we had. Dad, is it okay if I relate to your son what we just talked about? And so acknowledge the fact that the family cares, that they're there to do everything that they can, and let them be part of the team. So sometimes I think all of us see that person walking down and our heart sinks a little bit because this can be a challenge. It's important to take that challenge head on and acknowledge the fact that this person cares and wants to be the hero. I want everything done. This is, of course, always the most difficult thing, I think, for us because often we can end up on 2 pages. And what I have to say about this is I think that I want everything done. What everything is always a matter of really the debate. What does everything mean? And so in this situation, communication is important. And I'm going to draw on a real expert on communication, Tina Fey. I don't know if anybody's read Bossy Pants. Great book. So she has these rules of improvisation that are really, I think, are important here. So the first rule is that you always agree. So, of course, improv comedy, you have to go with whatever's on the stage, whatever's in front. As soon as you say no, the whole thing dies. No one's interested. And if you're in a situation, particularly if it's tense, it's always important to go with the flow of the conversation. Don't try to redirect. Go with the flow. Respect what's been said. it's not that you have to necessarily agree to everything. It's yes and. I know I know there are options for my dad. Well, yes, there are options. And there are things that we can also do to control his pain and to maintain his quality of life. As soon as the word no comes out, then we're on the other side of a negotiating table. So yes and is the key. It's always important to keep statements short and clear. No lectures. We already know 10-15% of what we heard last week or remember. So as soon as you get in the lecture, just think about the fact that 90% of what you're saying is just going right out the window. And lastly, there are no mistakes. So it's important to stay positive. It's important to stay an advocate and never be defensive, because we're all doing the best that we can. If we make a mistake, we're all doing the best that we can, and that should always be the goal, and it's important to make that clear. So Tina Fey has all of this right, I think, in our situation. All right, so I'm going to conclude there. I want to acknowledge this group at Tony Bach, who's at University of Washington, and what I'll call the Anka Talk group, has written books, and I really want to put a plug in for this book. There's also a website that anybody can go to that has lots of short videos and vignettes that really isolate how to communicate with very specific scenarios. And so anybody that teaches communication, anybody that feels that they struggle with communication, I would really encourage you to go to this site and look at what's there. And I have to also credit Toby Campbell at our institution, who's created a We Talk program. We, this year, have taken this on in the Department of Medicine. Every member of our Department of Medicine is going through a small group session to learn how to improve the way we communicate with seriously ill people. So I'll end there. I'm happy to answer any questions, and I hope I can leave behind some messages that are worthwhile.
We often get the question, what would you do if this was your parent or you or your child? Obviously, we all bring a bias into what we're doing. We've seen the best and the worst. So how do you turn it around to where it's an individual answer for them and not what you would do?
Sure. Well, I would say I take a pretty simplistic approach to that, because do any of us not think about that regularly? I mean, when you see somebody, God, I feel so lucky that I'm not in that poor guy's shoes. And so I do think about that, and I tell people I think about that, but that I really don't know what it's like to be in your shoes. So here's what I can imagine I would do, and here's why. That's literally what I say. And I think that people value that, even though I make it very clear, I'm not in your shoes, I don't know. I see you 15 minutes, every so often, 99% of your life. I'm not sure what that's like. So it's important to think about what's important to you.
I work for a pediatric institution. So your talk was amazing, absolutely amazing. But one of the challenges I think we have is, especially for our adolescent patients, where there's this sort of disjoint between what the parents think they know and what the kids know. Like, the child knows they're dying. The child knows they've relapsed, and the parent is trying to protect them. So I don't know if you can give us any sort of guidance as to how to sort of broach that with the parents, and so that you can honor the child but also honor the parent.
Yeah. You're raising an issue that I'm happy that I've not been in, because I know that some of our pediatric transplant doctors have been in a very clear situation where the parent doesn't want the child to hear any of this news, and I know that when the patient's truly a minor, they'll accept that up to a certain age, and I don't know where they cut that off. I think to the degree that I can imagine being in that situation, I would hope to communicate very freely about my feelings about what should occur and why I think it would be important for the child to hear the same information. Again, I've not been in the situation of delivering bad news to a child, but my feeling is that probably children would handle that better than maybe the parents even, depending on how it's delivered, and that sharing that kind of information with the parent might be really important. I do a lot of permission asking. I ask people permission to do everything. Is it okay if I talk about some bad news? Is it okay if we shift focus and talk about the labs? And this way it gives people a chance to feel like they have control over the situation. I think their parents want control. And so the more that control is shared by asking permission, the more maybe you're allowed to direct things the way you think they might go. So I don't know if that helps, but that's, I think, a very difficult situation. Okay, thanks for having me. Okay.